Afternoon, everyone. It's so wonderful to see you all here today. We have an awesome team that loves each other very much. I learned in getting ready for this time together from the Duke OBGYN department from maternal fetal medicine. And so we're first going to be hearing from Alexa, who is a third-year medical student that's working under the mentorship of Jeff and Saran to present some interesting work that she's done around discrimination and health outcomes among our comunidad Latina here in Duke. And then we're going to be hearing from Tori, who is a new person that has joined the department that is dedicated to engagement. She's an engagement specialist. I had the opportunity to listen to her either a couple of weeks ago in Grand Round. So we welcome you, Tori, and the team, and are excited to hear what is happening in Duke OBGYN.
I just want to say a brief hello and thank you to the Latin 19 group. My name is Saran Wheeler. I am one of the OBGYNs here at Duke, and I'm a high-risk pregnancy specialist. I also serve as the Vice Chair for Equity, Diversity, and Inclusion. So I did just want to really say hello to this group, a real thank you for being welcomed into this space, and to offer both myself and Tori, who you'll get to hear from briefly, as a resource and a partner to this group. We really value the work that this group has done. As you guys are well aware, you are national leaders and a national example of what this type of community engaged work can look like, and have really served as an inspiration to our department. So we're thrilled to be here. Jeff, I don't know if you want to say anything brief to introduce Alexa, and then we'll jump things off. But thank you again for letting us be here.
No, I agree completely, Dr. Wheeler. Thank you so much to everyone here at Lat 19 for inviting us to present today. Alexa is one of our third-year medical students here at Duke. She's been doing her research here, really focusing on building her skills in quantitative research methods, as well as learning a lot more about health disparities and how they interact with health. She spent the year not only taking stats classes and learning how to analyze data herself using programs such as R and Stata, but also completed the health disparities curriculum here at Duke as well. And she's been really focused on questions about how racism impacts pregnancy outcomes, and how researchers may, through adjustment for things such as morbid conditions, may sort of inadvertently and sort of with good intentions but accidentally block some of the ways in which racism might impact some of those outcomes. So I think the work she's doing is thought-provoking, and I think really highlights the importance of careful attention to these kinds of considerations in research design. And I know she would love to share her findings with you. So with that, I'll turn it over to her.
Wonderful. Thank you for that introduction, and thank you everyone for having us. I'm really excited to be here. I will remember to slow down my speech. Okay, I'm going to share my screen. Okay. Gotcha. Okay. Does that look good to everyone? Excellent. All right. So as Drs. Wheeler and Federspiel mentioned, I'm a third-year medical student here at Duke. And my research was looking at how kind of racial inequities in preeclampsia, and particularly how discrimination relates to preeclampsia, which is an issue of high blood pressure in pregnancy. Preeclampsia is one of the most important causes of maternal morbidity and mortality in the US, which is much too high, particularly among Black and Brown and underrepresented minorities. So when we were thinking about pregnancy outcomes, particularly preeclampsia, which has major racial disparities, we know that this is a result of racism, both on a structural level and an interpersonal level. And when we talk about preeclampsia, we often refer to chronic hypertension and obesity as the kind of the most important risk factors when we're thinking about likelihood of developing preeclampsia in pregnancy. But sometimes when we're, especially people focused on the obstetrics, we're thinking about how discrimination and racism affects, leads to preeclampsia. Sometimes we like to adjust away or control for things like pre-existing conditions. So that was kind of where our research started. So this is a logic model that I created. It looks a little overwhelming at first. So
Alex, if you can interrupt for just a moment.
Yeah.
There's just a request from the audience. Would you mind just pausing for just a moment and just kind of outlining a little bit more about just kind of reminding folks what preeclampsia is and it's kind of its role in obstetrics?
Yeah. So thank you for that. So preeclampsia is something that develops usually kind of later in pregnancy. It's associated with high blood pressure, but it's not just high blood pressure. We often see kind of end organ damage, so like protein in the urine from kidneys being damaged, and it can have a whole host of kind of other impacts on the body, and it can be really dangerous. Blood pressures can get very high. Sometimes we see things like eclampsia, which are seizures. So it's a really important thing in pregnancy too, because it often, if it develops early, we sometimes have to deliver people early in order to kind of help treat the preeclampsia if we're not able to medically manage it. Obviously, we never want to deliver early if we don't have to. So it both can impact mom in that sense and also infant if we have to deliver early. So kind of can act on both sides of things. Okay. So I'm going to go to this, which looks a little overwhelming, but the point of this model is just to say we have this kind of structural racism and root causes. And when we're thinking about kind of the non-biomedical causes and that increased risk for preeclampsia, we have kind of all these things that are very intertwined, thus the lots of arrows on the screen. But we think about, social drivers of health. And then there also kind of how psychosocial factors and health behavior factors kind of impact things. What's most important when we were thinking about this project was this short little arrow that represents the pregnancy timeline, which is often what we like to focus on in obstetric research. But when we're thinking about kind of what leads someone to be more at risk for preeclampsia, we recognize that kind of all these factors have a lot more time to impact someone over their lifespan and lead and impact their kind of pre-pregnancy health more so than they just act during pregnancy. So this is kind of why we're thinking about obesity and high blood pressure, and wanting to focus on how some of these factors impact this pre-pregnancy health, because, we think that probably birth to time of pregnancy is, more important in accumulating kind of risk in terms of like weathering or allostatic load kinds of theories. So we decided to focus on racial discrimination. And let's see. Oops. Okay. So we came up with the question of, is self-reported racial and ethnic discrimination associated with chronic hypertension and obesity? The self-reported racial and ethnic discrimination was measured using this tool called Experiences of Discrimination, which is basically like a 9-question, very commonly used in kind of discrimination research tool that basically asks, have you experienced discrimination in any of these 9 scenarios? And so these include work, policing, getting a mortgage, on the street, and a store. So kind of and during medical care, so a variety of situations. And we chose an obstetric cohort with about 10,000 people recruited in the early 2010s, which is a very exciting data source for us because it was focused on these non-biomedical and psychosocial and socioeconomic factors in terms of collecting data from participants. So there's a lot of information like income, education, which we normally might have, but also things like a discrimination scale, measures of really detailed diet and exercise, anxiety, stress. Nulliparous means people who have not given birth before. So they may have been pregnant at some point, but they never have given birth before. So all basically new parents. So let's see. Okay, so that's kind of the data source that we decided to work with. So let's, oops. Okay, so this is just kind of looking at some information that we stratified to see kind of what this cohort looked like. So when we looked at people reporting high discrimination, and EOD stands for experiences of discrimination, 3 or more among that 9-point scale is kind of what people tend to use as high discrimination. And this is racial or color-based discrimination specifically. You can see that the proportion of people reporting high discrimination based on race is understandably much higher among non-Hispanic Black and Hispanic as compared to non-Hispanic white. And then we also looked at kind of just the baseline obesity prevalence, as well as chronic hypertension prevalence, which, always higher among non-Hispanic Black. Our Hispanic group actually had a slightly lower rates of chronic hypertension, but did have higher rates of obesity than our non-Hispanic white group. And then looking at preeclampsia, which is kind of what all of this is about, is thinking about how many people get preeclampsia, and the pattern kind of continues to hold there. So the next thing we did was we looked at how among people reporting experiences of discrimination, we separated them out into those reporting 0, those reporting 1 to 2, and those reporting 3 or more experiences of discrimination. And we looked at what the prevalence of obesity and chronic hypertension were when we separated those out into those groups. So among people who said they have never experienced any kind of discrimination based on that scale, about 20% of them had obesity or chronic hypertension, whereas those who reported 3 or more experiences of discrimination, 35% of them had obesity or chronic hypertension. So this is just kind of the raw data. We didn't adjust for anything in this graph. So the next thing we did was we built a model, and we, added in a lot of factors to try to take out the effect of diet and exercise and some of those other things, and kind of isolate the effect of experiences of racial discrimination and how that relates to chronic hypertension and obesity. So from that, this is how we got this odds ratio, which basically tells us that among those reporting 3 or more experiences of discrimination, so high kind of racial discrimination by our definition, they were 66% more likely to have chronic hypertension or obesity. And we have a confidence interval here that just kind of tells us that it's statistically significant. So we think that there's probably a real relationship between experiences of discrimination and obesity and chronic hypertension. So the next, and I think more important part here, is we then stratified by race. And so what was interesting is, first of all, the same graph we showed before in the last slide, but now separated out into non-Hispanic white, non-Hispanic Black, and our Hispanic population. And looking at how among those reporting 0, so in blue is those who reported 0 experiences of discrimination, and then gray is those reporting 3 or more, what their prevalence of this composite of obesity and chronic hypertension was. So for example, among the Hispanic group, those reporting 3 or more experiences of discrimination had about 30% of them had chronic hypertension or obesity. So before, when we didn't separate out into racial groups, there was this 66% kind of increase in likelihood among those reporting high experiences of discrimination and then obesity and chronic hypertension. So they were 66% more likely, just looking at our whole population. But then when we kind of separated it into racial and ethnic groups, what was interesting is we saw in some groups, well, in all groups, that relationship was attenuated. It wasn't as strong in groups. And so just kind of our first interpretation of that is we think experiences of discrimination between racial and ethnic groups is more important than experiences of discrimination, differences in experiences of discrimination within racial and ethnic groups when predicting obesity and chronic hypertension. But that's more specifically, especially for the non-Hispanic Black population, where we really saw, among non-Hispanic Black folks, there was only a 10% people reporting high discrimination were only 10% more likely to have obesity or chronic hypertension. And this was like a non-significant result. So we're not sure if there's even a real relationship there. But the relationship that persisted the most in terms of those, when we looked within the Hispanic subgroup, there was still a relatively persistent relationship between how much discrimination they've experienced and likelihood of obesity and chronic hypertension. We thought this was interesting because, looking within the 3 racial and ethnic groups that we have enough sample size for, obviously the Hispanic group is an ethnic group, which includes people of all races, versus kind of these groups where one race is isolated. And we think, discrimination, particularly within the US, is often color-based. Obviously, that's not the whole part of it, but we think that the Hispanic group is probably a more diverse group in terms of skin color and how that might, this was not something we tested, but it's kind of something we were thinking about and trying to interpret these results. So, but basically we saw that there was, we think kind of within the non-Hispanic Black group, there's probably like less variation, because we think people probably, if you're Black in the US, you probably experience discrimination. I mean, that's just a reality of racism in the US. And there seems to be more variation in the experiences of discrimination and how that predicts obesity and chronic hypertension within the Hispanic group. I think I might have that might have come out a little confusing, so I'm happy to clarify. But we wanted to kind of talk to you guys because, we wanted to hear from you about what you guys thought of kind of these results of kind of persisting relationship within the Hispanic subgroup. And just hear from you about what you thought about these as we're interpreting our results. So thank you guys. I'm happy to repeat things and try to make them more clear, since I suspect I came off a little confusing at the end there.
Thank you, Alexa. I thought you did a great job. It's incredible what you've done in your 3rd year as a medical student. So I'm super impressed with this work. And I think it's so important. And we're grateful that you're here to share this with us. As people put together their questions. I do have a question of my own that may help us understand and interpret the data a little bit. As you mentioned, of course, there's a lot of diversity within the Hispanic community, the Latino community, in terms of racial diversity. And there's also a lot of diversity regarding how people have been racialized. So, for example, there's really interesting research in this area around immigrants, right? Where we see immigrants have better health outcomes than people that are US born and across generations. And that's part of one area I've talked to Saran about before, about just being really interested in understanding. So we know here in for example, here in our local community, a lot of the immigrant population, the Latino immigrant population, they don't know what their race is, and they haven't been racialized. Their kids do. Their kids do know their race, and they experience higher levels of discrimination. And so that has a negative impact on their health outcomes. For this sample, do you all, is there any access to data on immigration status and also country of origin?
Yeah, so that's a great question. So yes, we do this. I think I even have, yeah, so this is data among, so anyone who identified as Hispanic, the study asked them kind of what within the Hispanic group, what they identify as. And so among our population, almost 40% identified as Mexican. We had a large percent who were other, but when I looked at the data specifically, most of the other, more than 3/4 of them, said that they were Dominican. So that was another big portion of this sample. The other kind of part of that you asked about was, we do have data on how long they've been in the US, which I think would really get at kind of what you were discussing in terms of people who have been racialized or who have even experienced kind of the American. We are hypothesizing about its impact on health outcomes, but we have not looked at that. Okay, and Dr. Martinez Bianchi, let me try to answer that question. So her question was thinking about kind of what I said about within and between groups. So the model that we started with included everyone in the sample, right? And we saw this relationship between experiences of discrimination, so high discrimination and obesity and chronic hypertension. We took the exact same model, didn't change anything, but then we looked at within racial and ethnic groups. So if all of the racial and ethnic groups had that same 66% odds ratio, that would mean that, it's not race-based. It would mean that the relationship has nothing to do with someone's race. It just has to do with experiences of discrimination. If it was uniform across race, because we took the same model and then we split it into racial groups. So, I think the kind of null hypothesis would have been that it shouldn't, if it's only just experiences of discrimination, we shouldn't see a difference in the findings from this odds ratio or this increase in risk when we're looking at within racial groups, but we did. And in fact, it seems like, especially within the non-Hispanic Black population, there's practically no relationship between number of reported experiences of discrimination and their prevalence of obesity and chronic hypertension. This is adjusted for some things like diet, exercise, resilience. But so we thought it was really interesting that when we're looking when we separate it into within groups, this relationship doesn't persist as much. So we think that what's driving this 66% relationship is more how much racial groups differ in the number of kind of experiences of discrimination they have. And it's that's kind of driving the relationship. Because, I think I showed at the beginning, people who are non-Hispanic, Black, or Hispanic are reporting a lot more experiences of discrimination than those who are white. I hope that is helpful.
Thank you, Alexa. Let me see if I understood. So it sounds like in the initial group, there was some kind of relationship to where if you had more episodes of discrimination, there was a higher chance that you had obesity and hypertension, right? Just pulling back all my statistics here. That's what the 1.66 is for everybody else who's out there like me. It means if you had these, you had a higher chance, but it doesn't mean that they are the cause, right? It's just a noticed connection.
Correct, exactly.
Okay. So that's in the big group, that's everybody. But then if you broke it down in the Hispanic group, the more times you experience discrimination, the higher chance you ended up having obesity and hypertension.
Yes.
But that wasn't the case in the other groups.
Yes. So actually, none of these relationships were technically statistically significant. But
can you explain what that means for the folks in the audience?
Yes. I realized
Thanks.
just as I said that. So statistical significance is something that it's a way of interpreting whether or not how precise our estimates are, and kind of identifying whether we think the relationship in this, more discrimination equals more obesity, whether we think that's a real relationship or could just happen by chance. The statistics kind of help us identify what's the likelihood that this is just random chance that within our sample, more people who had more experiences of discrimination were also more likely to be obese, or was it actually a real relationship that was driven by more than chance? So when we say something is statistically significant, we think it's not just random chance that's producing this relationship.
Like there's some connection, we're just not exactly sure what it is.
Exactly.
It's not a fluke. And
Right.
so in the Hispanic group, it was statistically significant.
It wasn't.
So it wasn't, sorry.
Wasn't. In our first round of data, it was, and then I had to exclude some people that my data hadn't previously excluded. And because more Hispanic folks had missing data, our kind of precision of this estimate decreased. And so it technically went from statistically significant to not. It seems to be a result of sample size, because the fewer people we're looking at, the harder it is to say something is not a fluke. If you're only looking at 10 people and you see a relationship between obesity and experience of discrimination, you say maybe it's random. If it's 100,000, you're more likely to say, okay, this is less likely to be a fluke. So, I think statistical significance is very useful, but especially when we are hypothesis generating or thinking about kind of underlying trends, it's still important to think about what, the Hispanic subgroup had the greatest magnitude of a relationship. It's possible this was from random chance, but it's also possible it was not. And so I think it is notable that the highest magnitude of a relationship when we looked within groups was within the Hispanic group. And also, if you kind of look at the data here, where you can kind of see this clear step up from, 0 experiences of discrimination to more, you kind of see what we think this is kind of telling us, that within the Hispanic group particularly, it might still be pretty important how many experiences of discrimination people are reporting.
And it sounds like that is one of the questions for this group, right? If we are to say that this is a real relationship, what could be some of the reasons that the more times you have discrimination, you also end up having obesity and hypertension? Is that right? Is that what we're asking the group? Like, what could be some of those theories?
Yeah, and I think kind of one of our kind of initial theories was thinking about the greater diversity in race.
Yeah.
And so that's why I brought that up. And then I think the point about number of years someone has been in the US and it kind of exposure to that racism is also a really good point that we haven't explored, and could be really interesting.
Thank you.
Yeah, thank you, Alexa. And great question. Very good interpretation and like rephrasing for us here on the call.